ايش اللي جاب السيرة يا أخي؟ الأنسر in Arabic. حبوب منع الحمل ما له علاقة في سرطان الثدي. حبوب منع الحمل تستخدم فيها هرمونات مشتركة، استروجين وبروجسترون، عادة بكميات ضئيلة جدا، عادة تستخدم فترات طويلة. تأخر الحمل قد يكون له علاقة في سرطان الثدي، تأخر الحمل وليس حبوب منع الحمل. وجود حبوب منع الحمل أحيانا تكون واقية من السرطان لسرطان مبيض، فهو هذا عكس اللي في راسك أصلا يعني.
Another question over here, first row.
بس العلاج بالهرمونات التعويضية اللي بعد سن ال50 يسمونه الهرمون ريبليسمنت ثيرابي، هذه قد تكون مسببة للسرطان، اللي هو الهرمون اللي تعطى جرعة عالية أو تستخدم في بعد انقطاع الطمث. والآن حاليا أغلب الأطباء يبتعدون عنها، اللي هو يسمونه العلاج بالهرمونات لتخفيف أعراض سن ما بعد ال50.
Thank you very much for all the speakers for the wonderful talks and the great data being shown after the forum discussion yesterday. Really, I enjoyed the discussion today and the data mainly. I mean, when we look now, we have more around 20,000 mammogram has been done. So in Al-Hassa, in Al-Madina, in Al-Qasim. I think now it is the time, I mean, to use this data and to analyze it, I mean, to come back what we discussed yesterday with really, guidelines which can help, I mean, the patients. Which surprised me, I mean, in Al-Qasim, they started now in 35, which is, I have not come across, I mean, any literature that, recommended, to do mammogram before 40s. Maybe they have their, explanation. I would like to hear, from Dr. if there's any explanation in which base you have, decided to go, in 35. Thank you.
Actually, on review of the literature, including the researches running in Al-Qasim Region Oncology Center, reviewing all the cases from, presenting cases from 85 up to 2004, more than 50% of patients, or of cases, patient less than 50 years, 25% of them less than between 35 to 40 age. And also with the review of the literature of Saudi Cancer Registry and Mediterranean literature, which is showed that there is a younger age presentation. Actually, the Advisory Research Committee decided to start in this age, and after two cycles of mammography to re-evaluate and see. As I present that these 68 cases, more than 26% of them between 35 and 60 years. Yes, it is a due time to assess this fragmented screening services, not 20,000, reaching up to 50,000. Medina, I think they reach around 20,000, and I don't know, 20,000 screening. And here in the Mediterranean region, 8,000, we are 15,000, reaching up to more than 40,000 of client screened. According, if you analyze this, we can reach assumptions at what age we can start, and is it really we have to start in age less than 40 years? I don't know. We have to actually data conflicting. We compare it even in our data. It is time it is limited, so I did not present all researches. We have more than 6 or 7 researches in Al-Qasim region. Even we compare it with some research in Italy that most cases presented later stage T4, T3, T4, compared to Italian, it is T1 and T2. So we need, the data is conflicting, and we need evidence to support this.
Okay, I see another question there, and then I have also a question.
I have a question to Dr. Mushabbab Asiri and Dr. Haifa. I noticed in their presentation they are including symptomatic patients in their screening program, and this will lead to contamination of the data of the screening program. Especially in the Dr. Haifa presentation, which is she's representing the Ministry of Health National Screening Program. I think it should start on clear guidelines that it should be for purely asymptomatic patients. And all those symptomatic patients, they should have other channels to the hospital. We need a clear, non-contaminated data from our screening programs. Thank you.
That is also my impression, that there is, of course, in the prevalent round, a number of cancers that were clearly visible, could be palpable if they come to your screening program. But are you organized in a national screening committee, or are you all working on individually per province?
Yeah,
Individually.
Yes.
That's a shame.
Yes.
Yeah.
Yes.
That's a shame. You should
It's a big shame.
you should work more together, because you have to collect your data. You're all convinced that you're doing the right thing, but you are too small. Another question, what I'm really amazed me, you don't invite women. You make awareness programs, but you don't invite them. You have no access to women, because I think the most important principle for your program and all European screening programs is that you actively invite women. You send them a letter, you ask them to come, or you give them a fixed appointment. In the United States, they don't invite women. They have the awareness programs. They have no. That's also why we say in Europe, United States, do not have a screening program, because they don't invite. If you want to have a higher participation rates, because I don't believe that with your participation rates here that you really can run a screening program. With 8,000 women in a year, that is what I do in two months. I have 500 women in a week that I come for screening, and that's only 20% participation rate where I work. So I find your data, you must be able to attract more women. Okay.
Excuse me, you are saying it because you are doing it through a channel, you are doing it through the government, or you have an organization. So this is our problem. We don't have an umbrella. We are doing it through, or look at the conflict. Somebody changed even the age.
Yep.
So it should not be done. There should be, the government should take the lead, and clear guidelines should be, everybody should follow that clear good guidelines. This is our problem. Each organization works by itself. We are everybody following his own guidelines or certain guidelines. So you cannot, for me, I cannot force, or I cannot send a letter to anybody. I am not entitled to do this.
So there is no national cancer plan.
And unfortunately, even the one in the National Cancer Program may be not involved in this work.
Yeah.
You know, they are not the right people to be there, maybe in the first place. So I mean, this is a political issue, and for that, such a conferences, I think they are very important to highlight and shows that we are putting some force, shedding light and enforcing this in the government. This is our role as doctors in this community to really shed the light, and this is a demand from a community in general that we want this mission to be done.
I think that is also one of the important things of these conferences.
Yes.
But then there should out of these conferences come also a recommendation. And the recommendation should be something from more working together and inviting women to screening.
The answer is already done. Actually, there is national screening guidelines with the association with McMaster University, and already in at the Minister Office for signature. Actually, Dr. Sabbar Dabba, or the question regarding about why we included symptomatic patients. Our program is not screening, it is early detection. And our main targets, not screening, but increase awareness. When we start the early detection program in 2007, and maybe our colleague in Qasim before, our aim is not screening at that time. Just we try to get more services for cancer patients. At that time, there is only services in Riyadh and small services in Jeddah. Nowadays, I think we reach one of our goals. Now there is services in Dammam. Now there is building a center in Medina. There is one program here under construction in Lahsa. There is a program in Jizan, in Abha, in Tabuk, in Hail. This is one of the main things that we like to increase the service. This is one thing. Second thing, the initiative started by charity organization, either in Riyadh or in Dammam, Saudi Cancer Foundation, El Qasim, under the patronship of the wife of the governor of Qasim. It's all charity, because government at that time, they are refusing to do screening because cancer is not a major problem. We're talking about 1,000 cases per year for the whole country. So why you spend millions or billions for just 1,000 cases? And among them, just all of you, they will be detected. Nowadays, after 10 years of struggles, work, now the ministry is listening, and they start the national program. And the national program is going to pilot in Riyadh, and they will do it in everywhere. At that stage, all charity organizations should step back and they hand it over to the proper channel.
Sorry, Dr. Mushabbab, but when you start a program, you should call all the people who had an experience. You cannot sit by yourself and create a program alone.
Yes.
With all my respect to the people in Riyadh and to the minister and the Ministry of Health, if they want to start something like this, they should invite the leaders of this work in the kingdom and even outside to consult. You cannot bring few people with limited experience and they put it from out of their brain. With all my respect, this is, I announce it in public. Sorry, Dr. Mushabbab.
By the way, I'm not member of it.
Okay, I know you are not. I was a member in the National Committee of Guidelines. وبعدين انحطت الجايدلاينز بدناش نفضح حالنا بالانجليزي انحطت جايدلاينز.
لا هو استعنا ببعض التجارب سوري like القصيم the big
بعض التجارب
implemented for the screening. So we take Qasim and international experience also. And there was a consultant from WHO with us. Not from nothing, we start this program. And we start this program as a pilot. Yes, it is not working.
Open it.
I mean, if we want to start a national program, we should not start from scratch, and we should put all together. We put our hands on it and our hearts, because there are a lot of people. We want this to go. We want to put all our hands together and start it.
This is our next step. It will be, because we start our program as a pilot. You can say in Riyadh, and we see what is better for us. In Saudi Arabia, in regarding everything. So our second step to take all these under the umbrella of Minister of Health.
You don't have the right to take it. You have to involve them from the beginning. Yes. Then we will give you. You will not take it without involving people from the beginning. This is misunderstanding.
We have a very lively panel discussion.
No, I have questions from the guests.
Actually,
yes, there are questions from there are more questions. I hear more questions. I want to know how much time we may continue.
Actually,
what?
It is a nice, excellent
we have to stop
planning, but we did not involve all.
I think we
have to involve at some stage.
The panel discussion continues.
And,
I receive information that there is a break currently, so I think we have to continue our discussion within
just
the.
I will say one word. I want to send the regards to my colleague. The first director or executive director of program, Dr. Muhammad Ali Al-Habdan. He have to be with here, but unfortunately, some commitment forbidden him. And also, we seek help and advice from senior colleagues. They visit us in the region. Dr. Iman Baroum from Western region, and Dr. Nadir Isa, consultant radiologist from Dammam, I think, and they gave us a very informative recommendation, which has helped us too much. Thank you.
May I thank you very much for your contribution, for your discussion, and I think we initiated a debate here, and that's good. Thank you very much.
Good morning again, welcome. And we'll start the second session in this morning that will be moderated by Dr. Kwek Sweetian and Dr. Samira.
Welcome break from the break. And we will continue to hear about the breast screen experience from various parts of the kingdom as well as around the Gulf region. The first speaker will be Dr. Abdul Rahman Fakhro, who hails from Bahrain, and he will share with us on the overall, on the overview of the Bahrain breast cancer screening experience. Dr. Abdul Rahman is a breast surgeon who is also the president of the Bahrain Cancer Society, and he is also the chairman of the Department of Surgery at the Gulf University, as well as associate professor of surgery at the university. So without further ado, I will invite Dr. Abdul Rahman to the stage.
Thank you very much, Mr. Chairman. Bismillah ar-Rahman ar-Rahim. أولاً أشكركم على دعوتكم لي بحضور المؤتمر الدولي الأول للكشف المبكر عن سرطان الثدي بين الحاضر والمستقبل، والذي تم تحت رعاية الأمير سعود بن نايف أمير المنطقة الشرقية، والذي دشنه الأمير بندر بن محمد بن جلوي آل سعود. ولا يسعني بداية وأنا أتكلم باللغة العربية. احنا علمونا دائما نتكلم بالعربية، بس الطب نسانا العربي. أنا دائما أتذكر قول الشاعر، أعتقد أنه هو المتنبي، درسونا في الثانوية، احنا نسينا لما صرنا في الإعدادية. يقول: على قدر أهل العزم تؤتى العزائم وتؤتى على قدر الكرام المكارم. وأعتقد أن هذه مكرمة جيدة أن احنا نشوف في منطقة الإحساء تقدم الطب الهائل والإصرار على الانتماء لهذه المنطقة وتشجيع المواطنين على الكشف المبكر عن سرطان الثدي. طبعا هذا موضوع just start in English and saying this is very important issue, very critical. So to start with, we in Bahrain, when we did our campaign, it was done by the Bahrain Cancer Society. This is an NGO. It has not been started by the Ministry of Health. It took me more than 5 years to convince them to help us start this campaign. And we have signed memorandum of understanding with the Ministry of Health to support us, to give us the logistic support, i.e. to give us at least 3 or more of health centers to fix the machine and to start our campaign. However, I'm going to brief to you just, about our experience. And believe me, you have to start, as my colleague, when she said, we have to start from nothing and we have to continue. هنخربوا السلالات مالتي. سويتوا. Now when we ask ourselves, as breast cancer is a major national health problem in the Kingdom of Bahrain, we came to the answer with no hesitation, yes. we have problem with this. In 1990, Ministry of Health in Bahrain conducted a pilot study, and every one of you knows what is the meaning of pilot study. It was 800 women of age of more than 40 at that time. In conclusion, they said yes, that study found that breast cancer is very common in the community, and this was justified launching a breast cancer screening program. Now, everybody knows that according to the GCC, we are in Bahrain at the top of the list. Whether this is true or not, whether the Bahrain is a small country, or whether the Bahrain has, more education or more control of their, population, that we have at that time, 2005, 53.4%. Now, in the year 2007, this number increased to 54.4. Unfortunately, this is very sad to see, and it is really make you feel miserable. What cases we see in Bahrain? This is the cases we are seeing in Bahrain. Imagine when a patient comes to you with such, situation. And they make it more sad, and when you ask the husband about his wife, whether he knows or not, and the answer he will say no. And you can, explain this to yourself. This is another case. And when she came, she said to me that, do I have something nasty? I said, no, just mild inflammation. This is the case we see. Still, we are seeing these cases. Now, this is, of course, if you are a physician, you know that all of these are locally advanced disease. Now, according to the cancer statistics in Bahrain, you will find that in this histogram that the breast cancer is the top. Now, what is the second now is the ovary. It surpasses, the cervix, thanks to the pap smear for the ladies. Now, the pap smear has reduced the cancer cervix, and what remains is the cancer ovary, which is a hidden pathology. So you have to encourage, I think in the future, doing, sonography for the, pelvic sonography for the lady to detect cancer ovary or adnexia in general. What do we need then? Honestly, we need mass national screening program, and all of you yesterday, some of them are with and some of you are against, but I do believe, to the best of my knowledge, that we are in desperate need for, screening campaign. And I will tell you later why. Now, we lack a lot of proper statistics. We lack proper epidemiology, because when you are doing your screening, and by the questionnaire you can tell, you might have a clue about what is going on. But again, yesterday they mentioned that, nitrous oxide might be the cause of cancer. I have seen a lot of things, but this is not there is no evidence based, because when you tell the community that the cancer of breast is so and so and so, you have to be 100% sure. Now, we lack a lot of proper education and awareness, proper management. We lack, we need proper study. The sequel of a breast cancer burden, you don't know how much, the suffer and the agony the family will suffer. I have seen, a patient, when I ask her that when I diagnose her to have cancer of breast, the next day her husband will divorce her. This is very sad. Now, when we started doing this, and we were adamant to do it, we heard a lot of controversy. But honestly, we were adamant. We said we will do this. So we have to invite the Ministry of Health, told us, you have to bring the expertise. We said, inshallah, okay, we'll bring your expertise. We brought the expertise. And first of all, he said, no, you should not start doing screening at the age of 40. I told him, sorry, don't bring me the copy of others and tell me, and you want to implement it on me. We start at the age of 40, and I show him the statistics. He kept quiet. In general, what was his resume? He wants me to set a standard sequence of quality assurance. And we said, this is okay. Implementation of mutual cooperation. And I've been to the UK and I sat with them. Monitoring of the program, no problem. Training of technical, which is very important. All my colleagues yesterday, they elaborated on this, especially in the mammographist. You need somebody who did, you said how much yesterday? 5,000 you want? 5,000, you said mammographist, you have to do mammography?
For ours it's 1,000. I think 5,000 was the European standard.
Yeah, population of Bahrain is 5,000. Training of technical and clinical, staff, multidisciplinary assessment meeting, adherence to the international standard of screening, separate budget, and it was, very difficult for us to have separate budget, and we were begging, كنا نضطر طرارة, we've been, begging. And the only people who just, start to support us is the Bahrain Telecommunication, because they have a lot of money. So they gave us 500,000 BD. And this campaign cost us so far more than 1 million. 1,200,000, something like that. يعني 10 ملايين ريال, أكبر وأكبر. So separate budget line for different program activities. Political, which is the most important things, and community support. So having fulfilled all of this, first of all, we start distributing this booster. Now when you see in this booster, what do you see? We put this one, and somebody was criticizing us. Everybody, they have this, the habit of criticizing, not encouraging you, try to discourage you. Now, when we put this poster, what we said in Arabic, that if you want to stay in this portrait, then you have to do the mammogram. What is the wrong with this? There is nothing wrong with this. The lady is, half clear, because if she didn't do this and save her life, the mortality for her will be high and will disappear of this. However, and we gave them, a free line, free toll line. They can call at any times asking about, the campaign. Now, what was our mission? Our mission was very clear. Our mission was that, aiming for early detection. This was in 2005, by the way. Now more than how many years? 13 years? 8, how many? 10? 9 years? I don't know. You count it. The mission is aiming for early detection and management of this. This is lethal disease. Now we are not talking about, I'm not going to talk about, management and, staging or whatever it is. But this is, at the end of the day, will be a lethal disease. If there is, especially when there is lymph node metastasis. If it is regional advance, it's something else. However, but in general, this is a lethal disease. It is a killer disease, especially in the young age group. And in Bahrain, as somebody mentioned earlier, that he wants to do, the mammography at the age of 35, well, we have, a lot of disagreement. This is beyond these lectures. The main purpose was to achieve, this is the most important, issue in this. When we are talking about quality of care, it means we have to achieve a degree of health services for an individual and populations, not only the individual and population, that match the desired health outcome, which is consistent with the current medical knowledge. And you have to remember this. Now, screening methodology was, as I said earlier, 5, local health, and because it is a female disease, we've been obliged to arrange for this screening a female. So those who are doing the mammography are female, those who are doing the questionnaire are female, everything is female, everything, from A to Z. So how we encourage the women to participate? We have to educate. Now, before we started, we have to give lectures. Sit with the audience, sit with the community. I used to go to the school, addressing, the secondary school, and everybody asked me, why you have to go to those which are under the age of 17? I said, those are the future generation. They can sit and take to their mom, grandmother, or whatever it is, and they can, distribute the knowledge. So the knowledge become, among all the community. Posters, booklet, and this is what you need. You need a hell amount of budget. Then this is the invitation letter, which is very important. Now, thanks God, in Bahrain, we have something called CPR, Central Population Record. Every damn person in the island has a number. And this number is registered. You cannot receive your salary with this number. You cannot have electricity without this number. You cannot eat without this number. You cannot meet your wife without this number. So this number is mandatory. And we have to get, the number of ladies, whether they are Bahraini or non-Bahraini. We never discriminate. Disease is disease. So we send them a letter by mail, asking them to come for screening, which is free of charge, and the management is free, and we arrange for them to have, proper management. Now, each center I will show you later on, has mammography machine. And the most important things, if you want to do screening, you have to do your questionnaire, because from the questionnaire where is the location, whether these people, where this lady are taking, whatever it is, smoking, lab, if there is any sort of precancerous things you can detect out of this questionnaire. Now, we are very generous people. Those who never attend, we remind them again with another letters. And each letter, it costs money. But okay, we said, okay, we have to call them again. Now, all the mammograms films has been reviewed and assessed by 2 expertise. Expert radiologists at the Bahrain Cancer Society Hub. And this mammography assessment should be reported according to the BIRAD. Everybody knows about this. Now, the suspicious and equivocal cases, what we will do, we will send them to a third party to read them, whether agree or disagree. And this is only less than 5%, by the way. Now, this is the poster we distributed, for the public. Numbers, the telephone numbers, all of those, who are willing, they are most welcome. And this is the booklet. We used to educate them, and we give them booklet, telling them about, the signs and symptoms of the benign versus malignant, blah, 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 all of this, which you know better than me. Now, this is a pamphlet which we still believe that we have to encourage breast self-examination. I don't care whether this is, has become obsolete. Tell the lady, to do this. At least she will come to you sometimes and tell you that, I feel something wrong. What is the harm of you asking, why we are debating about something trivial? This is very trivial things, whether I'll do breast. I am not relying on a breast self-examination. I am just trying to educate the lady to know their normal breast. If she starts at early, then she will notice that there is something wrong when she is getting older and older. Now, Bahrain governorate, we have 5. Bahrain is a very small island, maybe a quarter of Al-Ahsa. And this is the area, just for your information, that have, 4 governorate in the main island and 1 in Muharraq, where is the airport there. And this is the machine. We supply each health center and each governorate, with 1 mammography machine. And this is the letter of invitation. And when we do for her this, and we finish, if everything is normal, we try to thank her for her attendance. And from my experience earlier, when I wrote thank you, all the investigation and the mammogram were negative. It was a mistake by me, because I forgot to tell them that, listen, if you have anything, you found it abnormal, then don't rely on this mammogram. Because what make me think to change it, because one of the lady called me, she said, I will take you to court. She will take me to the court. I said, okay, take me to the court. She stopped and she said, but you didn't ask me why. I said, do you want to take me to the court? Take me to the court. She said, no, but you have to ask me. I said, no, sorry, you want to take me to the court? And we are going front and back. She said, I've been now since, so and so for 2 times. I am doing mammogram and you are telling me normal. I said, really? Why you are doing mammogram? She said, because I have a lump. But you tell me this is normal, then okay, I keep quiet. I said, you have a lump, and I told you. And in our, screening anybody, any lady who has any history of breast disease, we take her off screening. Screening only for those ladies who came for toothache, and we ask her, do you have any mammogram done? She said, no. Then we'll take her for, for screening. This is the definition of screening, not those who have, surgery or disease, or she had mammogram before, or whatever it is. However, so we send them, a letter of invitation, and we send them, a letter of thanks after that, telling them that mammography, there is 15, if it is not more, of chance of missing your cancer. Stop me if I am, over time. And this is the questionnaire, and we have to, to fill this. Now, if you look to this, I put it, purposely. This is, the result when you are doing this. You have to put everything there. You have to be, sincere. You should not feel, fear or shy, or you want to, to keep something, down. When we have done, we have sent 52,000 invitations. Now, women underwent screening only 24th. And this is, acceptable, by the way. Even when I've been to UK with the CARC, they have started over 22 years. They sent invitation to 2.5 million. And the acceptance to come for this was only 73%, which is, this is, will be normal. Don't feel, what you call it, that you have done something wrong or disappointed. No. You will find that this is, true. That the number of cases called for further investigation, those we have, BioRide 3 or, suspicion or whatever it is, and they need further investigation, was 3,500. And those we diagnose them to have a cancer is 186. Now, this...
Dr. Abdul Rahman,
Okay.
it would be appreciated if you can wrap it up within the next few minutes.
Sorry?
It would be appreciated if you can wrap it up within the next few minutes. Thank you.
Okay. How long I have? 5 minutes?
5 minutes, yes.
Okay. Now, breast cancer screening campaign, this is total number of 186, 142 being followed, 44 disappear as usual. The mammogram we have done, this is, by age group. See the age between 40 and, and 49 is the lion's share, 9,000. Then it goes little down. We do some mammogram for those with strong family history or they have, whatever it is around only 200. And by age group, okay, you will find again total number of breast cancer cases is this, most at the age of 40 and 49. Now the education, unfortunately, this one, the first column, they claim that they are not educated. This is the illiterate. But will you see that the patients screened, that most of them between, the illiterate one and the university one. Now when you ask them, do you smoke? Most of the ladies are smoking, but they don't tell the truth. They said, we don't smoke, 17,000. And when we ask them about last mammography, you will find that, most of them, they have not done any mammography in their life. Do you practice self-examination? Most of them, they said, no. Now, the ratio of cancer detected by breast, we are comparing, when we did this, campaign, we encourage people, when they don't have, never done mammogram, we will do for them. But those who have any history, we send them to the tertiary hospital in Salmania, and we have discovered between 2005 and 2010 more than 600 cases. So in conclusion, the effective primary prevention, early detection, and effective treatment strategy can reduce more than 30%, and everybody agree with me, of breast cancer mortality. Now, despite the tremendous public awareness and pre-campaign education program about the screening, it is obvious that participation is still out of expectation and should not be disappointed. It's a matter of time. More effort should be spent to encourage and support participation in the screening program, and God bless all of you. Thank you very much.
Thank you, Dr. Abdul Rahman. We will keep the questions till the end of the session.
Okay, next presentation will be by Dr. Layla Abu Tahun. She is consultant radiologist and head of breast imaging units at King Hussein Cancer Center in Amman. And she has the Jordanian board in diagnostic radiology. And she has breast imaging and interventional training, multimodality approach in detection and diagnosis of occult breast cancer, European workshops on MRI-guided breast biopsies, and application training on hologic mammography.
Assalamu alaikum jami'an. I would like first to thank the organizing committee and Dr. Omar for organizing this idea. It's actually new for me that to meet in the region of the Middle East or this part of the world to discuss this important issue. And it's also important for us in Jordan because as working in a cancer center, we have some patients who are Jordanian and are being treated between Saudi Arabia and King Hussein Cancer Center. And it's good to know the background here and how we can advise them where to go. Or sometimes even if from Saudi Arabia, they come for treatment in the King Hussein Cancer Center. So it's a very good idea. It was very good to meet everybody and discuss these issues. I was asked to talk about the breast cancer experience in Jordan, about the King Hussein Cancer Center Foundation. The first, I will start with this question. I just added these 6 slides after the discussion and debates yesterday. The first question for all of us here, want to ask this question to ourselves. What was the clinical presentation of breast cancer 30, 40 years ago? If we think together, what was the presentation? Women were coming with palpable lumps or evidence of metastasis, bone lesions, lung nodules in the CT scan. This is how women were presenting with the breast cancer. And it was only in the mid-70s, not long time ago, when there was a major technical improvement, which is the mammogram, which made us able to find this small cancer before it's palpable. And this is, can you imagine, 30, 40 years ago, this great achievement. So the breast cancer is a progressive disease. It's a very important concept. It means before it is clinically detectable, it is there in the patient. We can find it by the mammogram. So when it's mammographically detectable, we can find it here. And if we find it in this preclinical stage, we can arrest the disease. So this is the whole idea about screening, and it's a very important concept. We don't want to find the cancer when it's big on the mammogram like this, or the patient comes with the cancer. We want to find it through screening. We want to find it through screening with this when it's a small tumor on the mammogram. And this is, of course, you can imagine treating this disease is different from treating this disease. So we having this data and keeping these images in mind, whatever argument we have about the screening, we cannot forget these images here. And I've taken these images from Professor Laszlo Toparo, who I consider he's my mentor, and I have been doing thing with him. So this is concept of, I have added these images only. Now I will talk about King Hussein Cancer Center, Jordan Breast Cancer Program, and I will introduce our breast imaging unit at King Hussein Cancer Center. This is the current building in the King Hussein Cancer Center. It was established in 1997 under the name of the Al-Amal Hope Center, and then in 2002 it was a change upon the desire of His Majesty King Abdullah and his wife Queen Rania to be named the King Hussein Cancer Center, who died with cancer. And this is the future building. Now, hopefully in 2016 it will be completed. The King Hussein Cancer Foundation is the governor body which governs the King Hussein Cancer Center and the Jordan Breast Cancer Program. We don't have a national screening program. The efforts are, we can call them breast cancer downstaging efforts. So these are all efforts to decrease the staging of breast cancer in Jordan. So among the King Hussein Cancer social responsibility against the fight of cancer, like the cancer control, the most important aspect which I will talk about now is the Jordan Breast Cancer Program. The establishment of Jordan Breast Cancer Program, the first question was why to have a screening program. This is the map of Jordan. It's a small country with a 6 million population. And you can see the age incidence here, that 3% are above the age of 65. And most of them are in the young and middle age. And the life expectancy at birth is 73 years. Breast cancer as we have seen in many countries is increasing. It's almost doubling. In 2010, 940 cases were diagnosed in Jordan. Breast cancer is the most common among females and the most common among also both genders, according to 2009 statistics. Again, in Jordan, the peak age is, as you can see, between 40 and 59, where 57% of cases are in this middle age group. And the breast cancer stages in Jordan were also in the high range, at stage 3 and 4 are the most common, as you can see. And that's why was the idea to start the Jordan Breast Cancer Program. And there were many main challenges I will put in these 4 groups. The first one was the capacity building. We needed, first of all, female technician mammography, female technologists. We needed training centers which can facilitate besides Hussein Cancer Center. And we did not have a comprehensive curriculum that mandate teaching mammography for radiographers. And we did not have manuals for the radiographers, which can be something national and recognized for everybody. On the other hand, the mammography services were lacking also the availability and accessibility of the screening services, unequal distribution all over the kingdom. There was no screening policy, and some regulation to screening again. Quality assurance also, we had no protocols or standard for operating procedures for the country or for local areas. There was no certification or accreditation bodies, and no monitoring of the performance. And also the public awareness was the 4th focus of the group. Generally, many of my colleagues talked about the cultural background, the negative attitudes for screening, and the lack of awareness about breast cancer and self-health in general. So the breast cancer program was established with the major goal was to reduce mortality and morbidity from breast cancer and to try to shift the staging. So we could not establish a general national breast cancer program, but we wanted to decrease the stage and to increase the awareness. It's governed by the King Hussein Cancer Foundation and the Ministry of Health, of course. Now, the strategic plan is started as a so-called bottom-up approach, where the focus was on the advocacy and awareness, then development of services, capacity building, and then to get stable funding, and finally, this will be probably years ago later on, legalization and free early detection for women in Jordan. And the quality and guidelines was in this group. The strategic plan was made to focus in these 5 groups: screening services to make it accessible and available, data information and policy for policy decision, quality assurance, public awareness and health education, and of course networking to sustain these efforts. I will talk about the achievements in each of these aspects. I will start with the screening service accessibility and availability into 3 main groups. First of all, infrastructures. The Jordan Breast Cancer Program had been collecting funds and trying to support units, so it has completed establishment of 5 units in the public health center. It had upgraded existing mammography units and established mammography units also in the private sector, and we have now 2 mobile vans. This is an example how the unit was before, like these were neglected rooms in the Ministry of Health, and this after the support of the Jordan Breast Cancer Program, where they had sometimes provide the machines, sometimes the sitting also. Human resource capacity. We have been conducting training workshops in Jordan, and also training for the radiologist, for technologist, for clinical breast exam. We have sent doctors, radiologists for observership at MD Anderson Cancer Center, and international courses on breast imaging also. This is for the last 2 years we have been conducting a screening mammography workshop where the radiologists are sitting there and leading screening mammograms. And this has been very useful, and this also training the radiologists on to perform ultrasound guided procedures. Now, what we try to call opportunistic screening projects. We had a large number of cases which we tried to so-called screening projects. These are not really screening, as we had the doctor even discussed before. We cannot always get pure screening cases in these projects. These are like, we have some sponsor who will give a fund to screen certain number of women. So there will be always other patients who are really symptomatic and to come in this. For example, we have a project screening 120 women. One was diagnosed with cancer. This was a screening of 900 Iraqi women by WHO and other organizations. 7 cancers were diagnosed. And there were other projects like 400 and then 2 cancers diagnosed. Which we are now, I think this is a good example now in Jordan. We are having the mobile van in the north of Jordan, and we are doing screening. We are trying to be very strict in the criteria. I will share with you the cases at the end of the presentation. How do we reach the woman here? By educational material through home visit. So the educator, they visit them at home, and they will give them the voucher and to take appointment in the van. And when they will do the mammogram there, we call them back for King Hussein Cancer Center. And so far, we had 14 cancers diagnosed. I will show you the details about them later on. Now, the second arm was the quality assurance. The first thing, we had no guidelines. We worked on the national screening and diagnostic guideline. The manual is already there, and we are working about 2 manuals now, one for the quality control to be standardized in the country, and the other one for the radiographer training. The other thing, the Jordan Cancer Program worked with the HCEC, Healthcare Accreditation Cancer, which is Healthcare Accreditation Council, which is a local organization for accreditation, and tried to develop with them the so-called breast imaging certification standards. And this has been a great experience actually, because now 5 units have been accredited with this. So we are trying to standardize the quality of mammography service in Jordan, which can be provided to women. And once this reaches a center level, we can then establish a screening program. The other arm, which is the public awareness and health education, this is through outreach activities, we have very active outreach programs. We are reaching a large number of women through education into schools, mosques, church, and open days, many activities. We have a training for volunteers and from different aspects to become educators. They have conducted training workshop for the men actually to be also involved in part of the screening. Mass awareness, we have been conducting since the 2006 October campaign, and on March, which is the Mother Day in Jordan, we conducted 2 campaigns, and these have good results actually, because now you can see these posters all over the places in Jordan, and when the woman will come to do mammogram, she will tell us, I am fed up with all this, which you are always telling me to do mammogram, so finally I want to do, I know what I have or no. So it has a good impact initially. And this is the impact, as we can see, with after this October campaigns, we are generally having increasing number of screening mammograms and also clinical breast exam. The fourth, fundraising and advocacy. This is the important source for collecting the money to sustain the program, of course. And data information for policy decision, the monitoring and evaluation of the GBC activities, they had their own guidelines to follow. And research and studies, we are working on this. They have published 2 papers about the experience of breast cancer in women, the background, the cultural aspect. I will talk about this group in focus now, national database. It's very important, as also colleagues asked yesterday, that we should have a national database. It is now, they made a registry book which distributed to all mammography unit, and the cases are entered there. The important that we are using the BIRATS reporting system by the ACR, so you should have a systemized system, so it can be a reference for you. The future plans now for that all mammography units should be certified according to the standards, and the idea is that we will have the guidelines for the quality control, guidelines for the radiographer training, and try to integrate these guidelines in the educational curriculum in the universities. I will share for you the mobile van. This is which I call now our very only fresh project in screening. So far we had screened almost 1,100 women. 14 cases were diagnosed with cancer, and the ages were 44 to 80. 10 had no symptoms, so these were real screenings. And 4 of these, they had symptoms, but they had said this for the technologists when they were inside the van, so they were accepted in the study. 2 cases of the cancers were less than 1 centimeter, so this is the beneficial effect of a screening. And this is, we can see these were invasive ductal carcinoma. We had 2 cases of lymphoma, I will share with you now, and DCIS. As a radiologist, I have to present the images because I think you can see this is the mammogram, the MLO views. We can see this small gram. This is 69 years old who's coming for a screening. So we found this is small cancer, invasive ductal carcinoma, less than 1 centimeter. You can see the magnification views, ultrasound guided by biopsy. This is really screening, and it's worth the effort. Another case, 44-year-old lady screening mammogram. You can see faint calcification here. We did for her, she could not fit for stereotactic biopsy because too small breast. We did wire localization, and this was ductal carcinoma in situ. So again, screening 44-year-old lady ductal carcinoma in situ. We are achieving our goals. Now this case, she was 47-year-old lady, and she had come to the van to do mammogram, but she had symptoms. She had feeling some lump or thickening, but they did for her in the van. And what we can see these calcifications here. Ultrasound, when you see calcification, expecting DCIS, so you have to be careful in your ultrasound approach, try to see the ductal changes. And we can see these like dilated ducts with some interductal hypoechoic findings. And we biopsied this part, and it was invasive ductal carcinoma. Another case, this you can see, she came for screening mammogram, and her mammogram is negative, there are benign calcification. But she came with these large lymph nodes, and we did biopsy from this long lymph nodes, and this was lymphoma. So screening mammogram, and you will find lymphoma from axillary lymph node biopsy. Again, she also came to the van, but she had complaint of left bloody nipple discharge. You will find invasive ductal carcinoma. It is almost less than 2 centimeters, but it's not less than 1 centimeter. This is the last case which you had come with a large palpable lump. She had denied it before, and it was proved to be lymphoma, primary breast lymphoma. I would like finally to introduce you to our breast imaging unit in the King Hussein Cancer Center, and the idea that in our center, besides at the beginning it was only a mammogram room, but the efforts was put because of the high incidence of breast cancer to make it a breast unit. So behind one door in one department you have all the breast imaging facilities, which I believe it's a great achievement for us in Jordan. So we have here the mammography machine. We installed digital mammography in 2007, and we have dedicated ultrasound breast machines. And also 2007 we introduced the stereotactic bond table biopsy, where we can provide biopsy for calcification or asymmetries or masses which are not seen on ultrasound for the whole kingdom. We had recently installed the best MRI with the best MRI with the best biopsy coil, and in 2013, which we really felt that we needed, because in the past years we have been doing MRI, but you know, sometimes if you do second look ultrasound and focus or magnification fuse, you don't find finding, it's difficult to follow up these patients. So if you are doing a screening or even diagnostic MRI, the presence of best MRI was helpful for us. We have done almost now 10 cases, and 3 were cancers, like this case. You can see she's a mastectomy patient with silicone implant. On the other side, this is small mass, and biopsies showed 0.6 centimeter invasive lobular carcinoma. This is another case. You can see the background enhancement, and this focus was new on the MRI, and that's why we biopsied. And again, 0.6 invasive ductal tubular carcinoma. So a screening mammography in our unit, we are performing both screening and diagnostic mammography. A screening, which we can call it opportunistic or whatever, it's not really screening. The woman is self-referred, she will come by herself, and we are doing online. So we are sitting there and we are doing the workup at the same time. So she doesn't go back home and come back. And the number is increasing since 2010. It's more increasing in a steady way than the diagnostic cases in mammography. Diagnostic cases in Jordan, we depend on the funding, because King Hussein Cancer Center, the patient has to pay, so they have to get insurance. So if they are referred to our center, we have cases. If not, they go to the other Ministry of Health.
Remaining 1 minute.
Okay. Building infrastructure of breast imaging. For breast imaging service is very important to have well-trained manpower, radiologist and radiographer, and awareness. I feel this had the great impact in Jordan, and teamwork, of course. Finally, this is the breast cancer symbol in Jordan with the hatta, and I would like to invite you also to the breast imaging conference, which will be held this year, inshallah, in October 2014, and this will be my email here if anybody is interested. Thank you very much.
Thank you, Dr. Layla, and we keep questions by the end. Next presentation will be presented by Dr. Iman Al-Baroum. She is a consultant radiologist and breast imaging Head of Radiology Department at King Abdullah Medical Complex, Jeddah, Head of Coordination Committee of Jeddah Breast Cancer Screening Pilot Program.
Assalamu alaikum wa rahmatullah. Thank you for the organizing committee for the invitation. I'd like to throw some shadow on our experience with breast cancer screening in Jeddah region. The program development started under the direct support from the Director of Jeddah Health Directorate in 2010. We studied the regional and international statistics that signifies the importance of the presence of breast cancer screening program, i.e. the justification of early detection of breast cancer. So we conducted workshops with leading companies in breast imaging to throw light on the workflow of such program. And also we did meetings with the region healthcare leaderships in main hospitals and in primary healthcare centers, because they are the recruiting force, and all heads of departments involved in the multidisciplinary management of breast conditions. And all these meetings is to discuss the magnitude of breast cancer burden in Saudi Arabia and the importance of screening program, and to outline the infrastructure of such program. What is the current infrastructure we have, and what is the needed infrastructure? So we summarized the infrastructure needed for establishing 6 units, and the infrastructure you need for any screening program is that you have to have a public awareness, you have to have a screening office that take care of call, recall, and invitation, and of course the equipment, the full field digital mammography units, and staff mammographers, staff radiologists, and the data center. The importance of the data center is to have all your images and all your reports saved in one place and for easy fetching. Now, currently, what's going on in most of the programs is that we're using either hard disks or CDs to save the images and the reports, with all the consequences of this method. The digital reporting of the mammography images, whether you have centralized or decentralized structure. The centralized structure meaning that you have a center of excellency or one fixed place that you make the reporting. So all the radiologists sharing in the reporting, they have to move to that place, which is really difficult sometimes if you are talking about a big city. The decentralized, if you have something like telemedicine or a connection of several hospitals, so the radiologist can do the reporting while he or she is sitting in its place. Quality assurance of the program, assessment clinics for the further investigated cases, and the multidisciplinary meeting, and of course the network interconnectivity. And these percentages determining our needs of these infrastructures. So the decision came of starting a Jeddah breast cancer pilot screening program. What are the justifications of breast cancer screening in Saudi Arabia? The breast cancer is an important health problem and the most common cancer in developed and developing countries. And almost 50% of breast cancer cases and 58% of death occur in developing countries. This from the Saudi Cancer Registry mentioned by all my colleagues, and is signifying that the incidence is 25.1%. And as we know, the Eastern, then Riyadh, then Mecca region. In Saudi Arabia, what's interesting in the Saudi Cancer Registry is that all the cases are infiltrating ductal carcinoma represent 78.7%, and the rest are different morphological types, but no carcinoma in situ in our cancer registry. And this indicates that we don't have the detection of early cancer. Although in some specialized centers, there are an increasing number of women presenting with early breast cancer and even DCIS, but the majority they are presenting with the regional disease, or 18% they are presenting with metastatic disease. I brought this slide to show that these 3 countries, Sweden, UK, and Australia, they have well-established nationwide screening program. And they have this ratio of mortality to incidence, 0.34 in Sweden, 0.31 in UK, and 0.25 in Australia. And this ratio is 0.43 in Saudi Arabia. So really this slide indicates that we're in real need of an effective screening program in our country. And this slide explains the burden on breast cancer burden in Saudi Arabia. Because of the growth and aging of the population, by year 2025, the incidence and mortality are expected to be 350% and 160% respectively. So this is a real burden that everybody is talking about. It has proven all over the world that early detection of breast cancer in order to improve survival remains the cornerstone of breast cancer control. And there is widespread acceptance of the value of regular breast cancer screening as the single most important public health strategy. Yet, nowadays, there is a lot of debate from anti-screening people about the usefulness of breast cancer screening, which has been well taken and explained by people who support screening with their evidence-based resources. The 2 main issues, the overdiagnosis and overtreatment. Therefore, it is justified to start a pilot breast screening program in our region. So what is the program inclusion, our program inclusion criteria? Inclusion criteria, Saudi lady, and why Saudi lady, as explained by Dr. Mushabbab Asiri early in this morning, because of the consequences. If she needed treatment, if she's non-Saudi, she will be facing a lot of problems if she doesn't have insurance. So that's why we included only Saudi ladies. And the targeted age group is 40 to 69. The total number of targeted age group, the total in Jeddah area is 225,000, and this statistic at 2009. In our pilot phase, only we decided to do 1% of the targeted group, and this is around 2,000 ladies. So our goals and objectives is to raise the public awareness through self-breast exam, clinical breast exam, and screening mammogram, with conducting different workshops for family primary health care physicians, and for the public also in different areas. We use a mobile mammogram unit, which is a contribution from Siemens company in collaboration with the Ministry of Health. And this mobile unit was moving between 3 primary health care centers at different regions in Jeddah for a period of 3 months. These are the three primary health care centers. And you know the client's recruitment in this primary health care center is poor. It's 157. So that's why you have to choose really the busy primary health care center that have a lot of clients to place your mobile unit. But also you have some constraints that you have to put your mobile unit in a safe place in a primary health care that have really a wide space and your equipment is protected. So there is a compromise sometime. I think this mobile unit has gone to Qatar. The workflow inside the trailer. At the entrance of the lady to the trailer, there is a reception for registration, and they have an electronic form to register all the demographics and the contact numbers of the patient. And then they give the patient, the client, we don't call it patient, serial number, and they write the name and the national ID, because we use the national ID as the fine number. On the trailer, there is a primary healthcare physician that has an electronic form, which is an access data sheet containing all the predisposing factors of breast cancer that is filled electronically by this primary healthcare physician. And she do clinical breast exam for the woman. And then she, on that form, I will show it to you later, she will choose whether it's diagnostic screening or no screening. And then she send the patient, if it's choose the screening, we'll send the lady to the technologist to do the mammogram, and then the technologist will tell the lady to come after 1 week to get her the result. Or they call her, in fact. This is the piece of paper that we are using in order to ensure that our data is purely asymptomatic women. So at the reception, they fill the national ID and the name, and then they send it to the primary healthcare physician. By questioning the lady and examining her, she will discover if she has any symptoms, so she will put a circle on diagnostic, so no screening mammogram will be done. But there is an agreement with the hospitals that such patients will have a quick access to be evaluated. If she encircle screening, S means screening, so the lady will go ahead and do the screening. No mammogram at all if the patient is lactating, for example, or she's pregnant, so no mammogram will be done. This is the electronic sheet that is filled by the receptionist in the trailer, and this is the access sheet which is filled by the physician, primary healthcare physician in the trailer, and in fact it's very easy to fill because all are drop menu and no writing at all. And this point has to be taken in consideration that if you want your physicians to help you in writing data for you, you have to give them an easy access to do those. Writing notes is really difficult and is a source of errors. The reporting workflow, it was a blind double reading. We used this form, where is the place for the first reader, second reader, and third reader for arbitration. And we used the BIRAT. The further investigation of suspected cases and their clinical examination has taken place in the assessment clinic in King Abdulaziz Hospital, and all the biopsied cases they were seen sharing in the two large hospitals, King Abdulaziz and King Fahad Hospital. Our results and performance indicators. The target population for this phase is 2,000 clients, representing 1% of the total. The total number screened is 1,167. The period of screening is 58 days. The uptake of our pilot study was 58.3%. The minimum accepted is 70%, and the mean age was 56.7. Our recall rate was 14.8%, and the acceptable is less than 7%. Our biopsy rate was 2.7%, and our cancer detection rate was 0.59%. 57% were invasive cancers, all were more than 1.5 centimeter, and 42.8% were DCIS. So the total number of cancers detected among those 1,000 women plus is 7 cases of cancer. So our post-screening mammogram assessment standards, we have to audit our program. So screening mammogram results sent within 2 weeks from screening was 76.4%, and after 2 weeks from screening was in 23.5% of cases, and interval from screening mammogram to assessment within 3 weeks was 52%, and after 3 weeks was 47%. Unfortunately, at that time we have Hajj vacation, and that's why we delayed the investigation of the patients. The time of biopsy results in less than 1 week is 93%, and in more than 1 week, it's 6.2%. This explains that we have a good histopathologist. They are doing their work very fast. And the interval from biopsy to surgical assessment, 2 weeks and less. 93% of cases were seen in the surgical clinic in less than 2 weeks, and only 6.2% were seen more than 2 weeks. The majority of our cases were BI-RADS2, around 60%, and only 6% were abnormal. We treated BI-RADS3 as abnormal that needs an immediate action. Nothing called in a screening program BI-RADS3 and you send the patient and you tell the patient you will do follow-up mammogram after 6 months. No, this shouldn't be in the screening program. The biopsy, malignant versus benign, the benign were 78%, and the malignant were 21.8%. We did some comparison with some breast cancer screening programs in the kingdom, they published in the journals. We compared our results with Al-Qasim pilot round and Al-Abdulatif breast cancer screening program. Our clients, the target were 2,000, Al-Qasim 9,800. Al-Abdulatif, they don't have a target because they are having walk-in patients. So they don't have target number of clients. The total number screened 1167 in Jeddah and 1,766. And Abdulatif, they enrolled until that period, when they published their period, 1,200. The period of screening, the total period of screening, we screened 1,000. We screened this number in 2 months. Al-Qasim, they screened this number in 1.5 years. And Al-Abdulatif, in 8 months, they screened this number of cases. So clients screened per month, in our case per month was 583, and 98 in Al-Qasim, and 152 in Al-Abdulatif. The mean age is almost the same. The recall rate is 14% in Jeddah, 31% in Al-Qasim, and 22% in Al Abdul Latif. But Al Abdul Latif, they have a high recall rate and a biopsy rate because they are enrolling symptomatic and asymptomatic patients. So this contaminated their statistics. The total number of biopsies is 32 in Jeddah, 25 in Qasim, and 83 in Abdul Latif, which is large. The biopsy rate in Jeddah is 2.7%, and in Al Qasim 1.5%, and in Riyadh 6.8%. The cancer detection rate, it's 0.59% and 0.24% and 1.3% in Riyadh. DCIS, we have 42.8%, in Qasim 20%, and in Riyadh only 1 case reported. Invasive cancers less than 1.5 we didn't have. Nobody have any invasive cancer less than 1.5. More than 1.5, 57% of our cases, and 80% in Qasim and 80% in Riyadh. So our points of weaknesses in this program is that we have low program uptake and high recall rate. So how to rectify these problems? Convert to higher program uptake by better public awareness and better communication with the primary healthcare centers, because they are the recruiting force. And the use of mobile units at primary healthcare centers, and choose the proper ones. I said in the presentation of Dr. Haifa that they're using static units in hospitals. I don't think this is advisable at all to use the static units used in hospitals for diagnostic purposes for screening mammogram, because the hospitals are already overwhelmed by patients. So either you have a fixed unit in a primary healthcare center or a screening center where there's no diagnostic woman should come there, or you have a mobile unit. Convert to lower recall rate by changing low volume readers to high volume readers. Of course, all our breast radiologists in the kingdom, they are low volume readers because we don't have a screening program. And the maximum number of cases we see per year is like 1,800 or 1,500 cases. So I don't think that we should follow the UK or European guidelines to be certified in reading a screening mammogram to read 5,000, because none of us will be able to read a screening mammogram. And how we change those low volume readers to high volume readers? By training through screening workshops. That is explained by Dr. Now. What they're doing in Urdun is really typical for improving the skill of radiologists, is that you do these workshops, you put like 500 screening cases in these workstations, and let the radiologist treat these cases by the help of an instructor. So he will become, or he or she will become high volume reader. With attending like 2-3 of these workshops, I think it will be good. From 2010 to 2014, we are lagging behind because we don't have sufficient infrastructure to provide continuity of the program. I do believe either you do it right or you don't do it. We don't have a screening office which has a rule in client recruitments, call and recall, and results distribution. And statistical analysis. Really what we're doing is that we are overwhelming our breast unit in King Abdulaziz Hospital in working as a screening office, which didn't work for a long time, because we are already busy with the diagnostic cases. And the mobile units, we don't have a mobile unit anymore because the company gave it to us for 3 months only. Also, you have to increase the number of mammographers and radiologists. The most important and the painful thing is the data center. If you don't have it, you will be having nightmares. Also, the digital reporting center, using a smart mammography information system, MIS, that allows double-blind reading and arbitration, as well as competent statistical analysis tool. This is the thing that we really need, and we have to enforce our PACS vendor to provide us with such things. And of course, quality assurance and the assessment clinics. And at least you have to have 1 or 2 assessment clinics in your city that work for 1 or twice weekly, and the network interconnectivity. At last, the dream came true, and we have a national screening program started in Riyadh, as you heard in this morning. But I think we need an advisory board of expert members in this regard from different cities of the kingdom. This advisory board has to be established as fast as possible, because you cannot say we have a national screening program and it is run with one city and then you have copy and paste. You cannot paste in different regions because we have to agree on, on several things. So the role of this advisory board is to unify the inclusion criteria and screening interval, unify the use electronic forms, unify the program performance indicators, and keep the program strictly audited by clear assessment standards and quality assurance measures, and ensure the presence of at least 1 or 2 breast assessment clinics that run once or twice a week in each city, and ensure the presence of regular weekly breast MDT to provide the standard of care of patients. So you have to have complete circle for the screening program from A to Z. So message to my colleagues, breast radiologists, be ready for increasing work burden and the need for higher skills. To improve your skills, you have to love your practice, you have to read, practicing more interventional procedures. Do not hesitate to attend workshops in breast imaging and intervention and MDT symposia all over the world, and keep yourself updated. I did a very brief comparison between the cancer incidence report, the Saudi Cancer Registry 2004 and 2009. It's interesting that everybody knows this piece of information is not new. This is 2004. The total number of breast cancer in male and female was 11.5, now became in 2009 13.5. Breast cancer among females, it was 22.4, became 25.1%. The age standardized rate was 15.4, now it's 20, no, it's not now, it's 2009, 22.7. The median age is almost the same. What's interesting also in the age-specific incidence rate is that the peak was at the age of 55, and the number of cases was like 55. Now, we have another peak in 40 years, and the 55 now, if you see, it's raised to around 60. And the 45, it is 70. If you notice, the 45 here was something like 45 or something. So really the incidence is increasing.
1 more minute.
Okay. The last slide is really interesting. It's showing that in 2004, we have a lot of 48.5% of regional disease. In 2009, this is reducing, and the localized disease was 24, and it's increasing. This means we are diagnosing a disease earlier than before. And really what's happened between these two, in these 5 years, is that screening mammograms has started in different hospitals or different regions. Thank you very much.
Thank you, Dr. Iban, for an excellent and very comprehensive lecture. Right, very good afternoon to all of you. Basically, for this session, I thought I will do some interesting case reviews on breast masses. And as I mentioned yesterday, what we do, and one of the requirements for radiologists to stay in the breast screen program is to have active continuing medical education participation. And one of the things they are required to do is to attend quarterly reviews on breast imaging cases. And at these quarterly reviews, what we review will be the missed cancer cases, as well as some cases of that are interesting, either in terms of management, or it could even be routine mundane cases just to keep us in touch with the daily work. So I thought I would just give you a brief idea of what we do in these cases. Basically, as I run through the cases, for the radiologists in the crowd, you may want to consider, is there an abnormality? And if you see an abnormality, whether you would recall the patient or not. And you can also put yourselves in the shoes of the assessing radiologists and think of what are the things that you want to do, whether you want to do MAC views or ultrasound, and whether you would biopsy the lesion or not. I was told that I was under the impression that the crowd was mainly radiologists, and that's why I prepared these cases. And for the non-radiologists in the crowd, I do beg your indulgence. I suggest you just sit back and enjoy the cases, and I hope I do not lull you into a preprandial nap. Right, so as I've mentioned yesterday, at the assessment, we do see patients who present with symptoms, and the first patient belongs to that category. It's a 42-year-old patient who came for a screening mammogram. And obviously, the mammograms are thought to be either normal or benign because she was not recalled for that. But because she complained of a right breast mass, she was seen in the she was referred to the symptomatic breast clinic. And on examination, she had a soft, non-tender mass. And of course, the surgeon, being a surgeon, usually when they feel a mass, they will send for an ultrasound. And this is the mammogram. If we can dim the lights a bit, that will be great. All right, just to show you the MLO views, and that's the CC view. So if you were the assessing radiologist and you see these mammograms, what would you do? Would you do additional views? Would you do an ultrasound to further assess this mass as suggested by the surgeon? Would you biopsy it? Or would you do none of the above? All right, so just to let you have another look at the mass. Right, in this case, the assessing radiologists, like most radiologists, are very easy and friendly. And because the surgeon asked for an ultrasound, they went on to an ultrasound, and this was what was seen. A fairly homogeneous mass that looks something like the subcutaneous fat. And of course, this is a patient with a breast lipoma, and this is a benign finding, and there is no need for biopsy. The patient only needs an annual screening review. And if you look at the mammograms again, you will see why this patient wasn't recalled. Obviously, there is a mass in the right breast, and if you look at the mass, you know, it is fairly low density. Even if this was a cyst or some other breast mass, it would be of increased density, and the fact that this is a fairly low density would suggest that this is a mass containing fat. And for most radiologists, if you see this lesion, you probably would not even do an ultrasound. You can just confidently make the diagnosis and just pass it along. All right. So for lipomas, basically on clinical examination, you will feel a soft mobile mass. Mammogram, we have reviewed the images, likewise with ultrasound. In terms of differential diagnosis, there really isn't much in the way of differential diagnosis, but sometimes if you do see some fibroglandular elements within the mass, it could be a hematoma. Now the next patient is a 41-year-old lady who came for a screening mammogram. And this is what the screening mammogram shows. Right, so there is a small mass in the right breast, like so. And would you recall the patient, and if you do, what further investigation would you perform? Would you perform magnified views, cone compression view, an ultrasound, or a combination of cone compression view and ultrasound? Right, in this case, they did a combination of the last, and you can see that on the cone compression view, it is fairly well circumscribed in one view, but in the other view, it is not very well circumscribed. Part of the margins are obscured. And I don't know if it's possible to dim the lights. If we can, probably the lesions will show a bit better. On the ultrasound, you can see a hypoechoic mass it's slightly lobulated. And if you look at this, the question for the assessing radiologist then would be, would you biopsy this lesion? If you look at the classical description by Stavros, he did say that you can see some gentle macrolobulations within a mass, but this should be less than 3. And for a mass like that, where it has quite a number of gentle lobulations, I think most people would proceed to biopsy the lesion. Right, thank you very much. And in this case, what we do is we usually do an ultrasound guided biopsy, like what you see here. And the diagnosis came back as a papillary lesion. So if you were the radiologist at the multidisciplinary tumor board, what is the further management? Are you going to say that this is concordant and return the patient to routine rescreen? Are you going to say that this is discordant and suggest a repeat of the biopsy? Or are you going to say this is concordant but still recommend an excision biopsy? Or would you go for a short-term interval follow-up? Right, I think I heard a couple of voices saying C. Right, basically if you look at it, the option that I dislike most is the short-term follow-up. That's what I call a passing the buck option, all right? Some people would suggest things like a short-term interval follow-up and then hope that it lands on somebody else's assessment day and let that other person make the decision. And usually in our screening program, we tend to discourage, quite strongly discourage short-term interval follow-up. And what we did in this case was like what some of you have mentioned. We'll say that it is concordant, but still recommend an excision biopsy, all right? Now, papillary lesions or intraductal papillomas, it's difficult to differentiate them from malignant lesion on imaging, and there is an association with proliferative and high-risk lesions. And in our practice, we recommend a surgical excision for all papillary lesions, and I will tell you why. In this case, what we did was we did a ultrasound hook wire localization, and we did a check mammogram as well, just to check the position of the hook wire. Again, I think this is debatable. Where I practiced previously at a different center, they didn't routinely ask for this, but at my current place of practice, the surgeons all want this. And as I said, generally radiologists are very friendly, easygoing people and will do it because they've asked for it. But I don't know, perhaps the surgeon in the audience can tell us whether there is any value to this. And this is just the excision specimen showing the lesion on both the radiograph as well as ultrasound. All right. Intraductal papillomas are basically benign lesions that are characterized by a fibrovascular core, and they are covered by epithelium. They can be located centrally, in which case they tend to be in the retroareolar region, and they are usually solitary if they are central in location, or they can be located in the periphery, in which case they may be multiple. And they can undergo secondary changes like hemorrhage. So you can appreciate how if they are a central lesion in the retroareolar region, and how if they present with secondary hemorrhage, they can result in a unilateral bloody nipple discharge. Whereas the peripheral papillomas tend to be clinically occult in most cases. And the important thing about the intraductal papillomas is that you can get foci of ADH or DCIS. All right, this is the excision specimen, and that's just a schematic diagram to show you the stalk and the papilloma, and that's the histological correlation. You can have a stalk, and as I've mentioned, it is lined by epithelial layers similar to that of the duct, and because of that, it can undergo the changes that you can see in the duct, such as ADH and DCIS. So when we do biopsy of these lesions, we just take samples of it, and because of that, we may actually have sampling errors and miss out on the foci of DCIS or ADH. And that's why for papillary lesions, we recommend excision biopsy, even if the percutaneous guided biopsy shows just a papilloma. Most of these tend to present as round ovoid lesions. You may sometimes see ductal dilatation, and occasionally, very rarely, you can get calcifications, both coarse calcifications or microcalcifications. And on ultrasound, they tend to present as an intracystic mass, particularly if it's a peripheral papilloma or a well-circumscribed hypoechoic solid mass if it is a more centrally located lesion. All right, so these are just some examples of intraductal papilloma. And sometimes they can just present with a ductal dilatation and a solid component within it. And this is just a large central papilloma with some coarse calcification as well as some fine calcifications. And as I've mentioned earlier, one of the common presentation is as an intracystic solid mass like so. We don't usually do MRI for these lesions, but in this case that we did an MRI, you can see that it's a round or ovoid lobulated mass, and it can have a variable enhancement pattern. Okay. Now, the next case is a patient who presented with screening mammogram. And I show this just to illustrate some of the issues that the breast radiologists may face when reading screening mammograms. All right. Now, in the interest of time, the lesion of in question is this little round nodule here. All right. I'm not sure how many of you would actually recall this patient. When I show this case to the audience, usually about at least half will tell me that they will not recall the patient. It's a very well-rounded, circumscribed lesion. Could be a small cyst or a small node. In this case, the patient was recalled. They did a spot compression view, and they said it was normal, but I think they may have missed it because it's probably further back. But fortunately, they also did an ultrasound, and this was what they saw, right? Small mass, probably about 5 to 6 millimeters. Again, if you see this, I'm not sure how many of you would recommend a biopsy for this, but in this case, they did a ultrasound-guided biopsy, and what do you think, benign or malignant? Yes, this turned out to be an IDC, and I'll tell you a bit more about IDC later on. But basically, I think this case illustrates the difficulty that the screening radiologist faces, whether to recall the patient or not. And I think there is a very human element to reading screening cases. Basically, if I were reading 50 cases for the day, and I had recalled 6 or 7 cases, and I were to see that at the end of the list, I probably would have a tendency to let it go and not recall. But if I had read 50 cases and I had only recalled 1 or 2 cases, I probably would consider recalling that because it's not going to really make my recall rate look bad. And because of this very human element to screening, that's where double reading comes in very useful, because it tends to minimize that human element involved in screening. And the other thing is, of course, what investigation to do. I think most times now for mass lesions, most people would at least do an ultrasound, although not everyone would do a cone compression or magnified view. And in this case, I think the decision to biopsy or not is fairly straightforward. But again, sometimes at assessment clinic, if you were to see 10 patients and if already put up 4 for biopsy, there is always the tendency not to biopsy the next case and to find some reason not to do the biopsy. So again, there is a very human element to that may lead to some errors in judgment. The next patient is a 41-year-old lady with a previous history of local excision for ADH. And this is her screening mammogram. Right, just another look at it. All right, this is a case of missed cancer. All right, if you look at this, there is obvious, there's loss of volume of the right breast. There's a bit of kink here from previous surgery. And if you look at this view, again, there is some distortion from previous surgery, and there is also a mass here from the surgical scar. And that was what one of the radiologists saw, and they decided to pass the lesion. But if you look carefully, there is a second lesion in the opposite breast, spiculated mass like so, and you can also see it in the MLO view. So this is just a very simple reminder to look at both breasts and not just to focus on one lesion and ignore the rest of the breast. So on the cone compression view, you can see persistence of the lesion, and of course on ultrasound you see the typical spiculated mass that is quite typical, and the diagnosis in this case was another IDC. I can't remember the details of this case, but this patient needed neoadjuvant chemotherapy, and what we did was we did a pre-chemo clip insertion. That's quite important because sometimes following the chemotherapy, the mass may disappear completely, and it may be difficult for you to localize the lesion. All right, so I do apologize, the images are a bit small, but that's where the clip is. And again, if you look at the post-treatment images, you can see the clip, but the spiculated mass itself is hardly visible on the post-chemo mammograms. So that again reinforces the importance of doing a clip insertion in these cases, because if you had to localize this lesion post-treatment without the presence of a clip, it's going to be very difficult. And on the excised specimen, you can see the clip, and the spiculated mass looks a bit more prominent in this case. So this turned out to be IDC, not otherwise specified. And basically, this is the most common group of invasive breast cancer, accounting for up to 75% of cases. It tends to be a fairly heterogeneous group with regards to the pathological and clinical cause. And the reason why we call this not otherwise specified or no special type is because these lesions tend to lack sufficient features to warrant categorization into any of the other special types of invasive tumors. And what are the other examples of invasive tumors? Well, they can be micropapillary or medullary CA, or mucinous or tubular CA. And because they are quite variable and a fairly heterogeneous group of tumors, the prognosis is highly variable. And they may be, the prognosis is related to a variety of factors, including the presence of lymphovascular invasion, the nodal status, the tumor size, as well as the histological grade. The common mammographic appearance, the classical appearance, is a dense mass with spiculated margins. Usually that is easy to identify. The ones that are difficult to identify is if they present with focal asymmetry or distortion. Again, if they present with associated microcalcifications, that's easy to identify. Most times, I think radiologists are quite good at picking up microcalcifications. On ultrasound, they tend to present as an irregular spiculated mass that is classically taller than white, and they can be hypervascular on Doppler. Now, the next case is another patient with IDC, and again, this was a case that was missed by one reader. All right. So, having told you that there is an IDC, which breast is it in? Okay, just another look at both views again. Any takers? Okay, very good. So yeah, absolutely right. There is a spiculated mass here, all right? And on this view, it's over here, not very apparent, and that's why sometimes the breast density may play a part in tumor diagnosis or missed cancer cases. If this had been more dense, I think it wouldn't have been so easy to pick up the mass. And in this case, the assessing radiologist went straight to an ultrasound, and that is the lesion, another IDC. So as we've mentioned, IDC can present with a spiculated mass like what you see here. They can be vascular. Occasionally, it can be a mass with microcalcifications, and as we've mentioned, if they do present with microcalcifications like that, usually it's very easy to pick them up. But when they present as a focal distortion, like what you see here, it may be more difficult to pick up both on mammogram and on ultrasound, and you really have to look hard for it. What are some of the mimics of a spiculated mass? Well, most times it's going to be due to a malignancy of sorts, whether it's IDC or ILC, or sometimes you can even have a solid DCIS. But do remember that there are other causes of spiculated mass, and this includes a post-surgical scar. And I've seen patients recalled for post-surgical scars and even had biopsies for that. And that stresses the importance of looking at the history. All right, always look at the screening form and see whether there's a history of previous surgery. The other causes of spiculated mass that we may sometimes see would be radial scar and fat necrosis. All right, so this is just to remind you of a post-surgical scar that can mimic a spiculated mass. Radial scars basically is another possible cause of a spiculated mass, and they are benign lesions of unknown etiology and natural history. And the important thing about radial scar is that they may mimic breast cancer on both mammography and ultrasound, and there is an increased association with breast cancer. They may be an incidental finding at an excision biopsy, or they may be detected on mammogram. Very rarely, they may present as a palpable mass. Classically, in terms of the imaging features, they can present with long spicules and central lucency. The appearance is said to be variable in two planes, and usually they do not present with a clinical mass. And in contrast, it is said that for breast cancers, they tend to have a dense central component as opposed to the lucent central component in a radial scar. They tend to be better seen in two planes, and they tend to have spiculations that are shorter than the diameter of the central mass. But I think in practice, it is not possible to really distinguish the two based on mammographic features, and most times we would almost always biopsy these lesions. All right, this is just an example of a radial scar, and you can see that on ultrasound, again, it presents as a spiculated lesion that can mimic a tumor. Now, this is the last case. It's a 64-year-old lady with a palpable breast lump. I'm not telling you the site of the breast lump because, again, this is one case that I've shown to various people, and they have told me either the wrong site or they have pointed to the wrong spot. So, another look at it. Which site is the lump on? Okay, I heard someone saying the right side. Okay. Basically, the lesion is on the left, all right? In the past, when I've shown people, they've called this a lesion. This is not the lesion. I don't think the lesion is visible on the mammogram, all right? We did an ultrasound for the patient because of the clinical complaint of the lump, and there was a very large mass from the 12 to 3 o'clock position, like what you see here. And on biopsy, any guess what the histology may be? All right, this was an ILC. So ILC, the second most common type of invasive cancers, they account for 5 to 15% of all invasive breast cancers. And the feature about ILC is that they have an insidious growth pattern, and therefore they tend to be difficult to detect clinically and on mammography. And they can present as just a very subtle focal developing asymmetry. And one of the features about ILC is that there is a high incidence of bilaterality, multicentricity, and multifocality. And that's why when we have patients with ILC, we tend to do MR to further assess the extent of the lesion. And that's the extent of the lesion in this patient. All right. So again, she required neoadjuvant chemotherapy, and we did a clip insertion. All right, that's where the clip is. And you can see that it's actually in the retroareolar region. And I don't think any of you saw anything there on the mammograms previously. This is just the post-chemo MRI showing resolution of the area of enhancement. And that's why it's important to leave a clip in these cases. All right. Again, another view of that, and that's the excised specimen. I don't think you can see any mass lesion within this. So very quickly for ILC, as we've mentioned previously, they are difficult to detect early, and there is a tendency to underestimate the size on mammography. The sensitivity of mammography for ILC is pretty low. It's only about 50%. If they present as a spiculated mass, it's easy to diagnose. But if they present as focal asymmetry or distortion, that can be more difficult to detect. Ultrasound is slightly more sensitive. It's got a 80% sensitivity, and usually they tend to present as irregular masses with architectural distortion. Just some images of ILC. If they present as a spiculated mass like that, it's easy to detect. But if they present as a focal asymmetry like this, you know, it becomes a lot more difficult. There's a tendency to pass it off as normal, and that's what you see in this patient. All right, and as I've mentioned previously, MRI is useful to look for multifocality and to look for lesions elsewhere. So I've given you a very quick run through some of the masses. Occasionally, masses are not seen on mammograms like what we saw in the last patient, and that's why it's always important to ask the patient whether they have a breast lump. And it's also important to remember that there is a false negative rate to mammography. As various speakers have mentioned, mammography is not a 100% detection rate. We've also looked at obviously benign lesions like the case of the lipoma. And in these cases, it is important not to biopsy them because that would result in an unnecessary biopsy. The difficult ones are really the benign mimics, like the little IDC that we saw. And basically, I don't think there is a good solution to this. That's always a dilemma that radiologists face, to whether you have a high recall rate or you have missed cancer. And to me, the underlying philosophy is really to pick up the cancer and ignore the recall rate if you have to choose one over the other. For the suspicious or likely malignant masses, generally the diagnosis is fairly simple, but occasionally you can get unexpected findings like radial scar or fat necrosis. All right. So I've given you a very quick run through some of the interesting case reviews that we occasionally present at the quarterly breast review tumor boards, and I hope you've enjoyed it. As this is my last talk for the conference, I would like to thank the organizers for the kind invitation and hospitality again, and thank you all for your attention.
We can call Dr. Abdurrahman Fakhru, Dr. Leila Abu Tahun, Dr. Iman Baroum, and Dr. Quick for a short panel discussion.
For Dr. Quick, about radial scar finding in mammography, you recommend it for image-guided biopsy or recommend from the start excisional biopsy?
Sorry, your question is whether I would do image-guided biopsy or excision biopsy?
From the start, when you found this is radial scar.
I think generally the tendency or my usual practice is to do image-guided biopsy because we try to reduce the incidence of open biopsy.
And you recommend image-guided better than to excise this radial scar?
This is, you're talking about breast lesions in general, or are you referring to any specific?
Radial scar.
Oh, for radial scar. Well, like I mentioned, I think in theory it's very you know, in theory, when you read the textbook, you get textbook description of radial scar versus cancer. But generally, in practice, I think it is very hard for you to tell whether it is a radial scar or cancer just by looking at the mammogram. And therefore, we usually do an image-guided biopsy, because if it turns out to be a malignancy and you have done an open biopsy without clear margins, you may have to go in again. So for radial scar, we will start with image-guided biopsy, and if it comes out as a radial scar, we would then go on to an excision biopsy.
About post-down staging of chemotherapy and